First of all, I would like to thank you for your presence here today. Good afternoon to all the board of directors of the Thống Hospital and professor and vice professor that are sitting here today. So I would like to report an article called Outcomes of Laparoscopic Cholecystectomy for Acute Cholecystitis After Percutaneous Transhepatic Gallbladder Drainage at Thống Hospital. This presentation has 4 sections. In section 1, I would like to talk about the background. In the background, we have already know that acute cholecystitis is a common surgical condition dominated by gallstone. The natural cause of it can cause to sepsis and even death if we don't treat it in time. Laparoscopic cholecystectomy is a standard treatment for acute cholecystitis and other gallbladder disease, and it is an effective and a minimal invasive procedure. Therefore, for elderly patients with severe comorbidities who are not suitable for the surgery, supportive treatment will be necessary. In addition to medical treatment, PT-GBD is an optimal procedure for temporarily relieve the biliary pressure and helping it to reduce the risk of biliary infection. This procedure is considered easy to perform, has few complications, and highly effective in reducing the mortality risk for patients. In 2014, at Hepatobiliary Department of Thống Hospital has commenced laparoscopic cholecystectomy and PT-GBD, and in 2018, at Tokyo Guidelines, its effectiveness and safety has been proven and advised. In material and methods, 35 patients diagnosed with acute cholecystitis due to gallstone had indication for PT-GBD at Hepatobiliary Department of Thống Hospital. These patients were admitted to the department for laparoscopic cholecystectomy when the condition is permitted from January 2022 and to May 2024. About the inclusion criteria, patients have been diagnosed with acute cholecystitis due to gallstone, which had PT-GBD to treat acute cholecystitis and laparoscopic cholecystectomy after that. Patient is discharged from Thống Hospital during the research time. Exclusion criteria: already PT-GBD at different hospital, gallstone in different location excluded the gallbladder. Research contents has 2 parts about common characteristics, including age, male to female ratio, history of abdominal surgery, comorbidities, and ASA classification, and the result of surgery. Is timing of PT-GBD and the duration of PT-GBD, method and duration of the surgery, blood loss during the surgery, complication during and after the operation, and the last one is post-operation stay length. This research design are retrospective and descriptive. And about the result, talking about the age, discussion, the average age was 71 years old, with majority of group is above 60 years old, takes up to 77%. The highest age was 92 years old and the lowest was 44 years old. Our research has the average age similar to the author, August Vista, which is 73.5 years. And distribution to the gender shows that the rate of male patient is higher than the female patient. In our study, there are 19 males and 16 females, resulting in a male to female ratio of 1.2 to 1. This differs from the study by author Đặng Soda, which reported a female to male ratio of 1.9 to 1. The study by Trần Văn Phờ recorded a female to male ratio of 4 to 1. We noticed that several medical conditions in patients that were not well treated, such as hypertension, diabetes, and cardiovascular disease. Hypertension, coronary artery disease, and diabetes were the biggest 2 groups in this study. According to Hickman, patients with symptomatic gallstone who have diabetes and more likely to experience biliary inflammation and complication compared to those without diabetes. We recorded 4 cases of patients who have history of previous abdominal surgery, accounting for 11.4%. Most patients are classified as ASA 3. ASA 2 only accounted for 11 patients. as Su Young-soo stated that PTGBD is an effective treatment for SSA3 patients before laparoscopic cholecystectomy. The studies illustrate that PTGBD has a very high successful rate. Other authors also show that the report reflects most of the PTGBD placements are succeeded. According to our study, the majority of the patients underwent surgery after PTGBD at more than 6 weeks, with 30 patients accounting for 85.7%, and 5 cases being operated on at 4 to 6 weeks, accounting for 14 to 14.3%, with the shortest time being 30 days and the longest being 120 days. Author Calorie recommends that early laparoscopic can be performed within the first week after the drainage in young patients without associated comorbidities. This research demonstrates that most of the cases were successfully operated with complete laparoscopic cholecystectomy. One case had to convert to open surgery due to the adhesive of the small intestine. According to Nghiên research was 16.7. The lowest rate of the conversion to open surgery belongs to Hoàng Mạnh An research. The main reason for converting to open surgery in most studies is due to the significant adhesion. Surgeons had difficulty in identifying clearly the relevant anatomical structure. The study recorded in this report, we have 2 techniques, which is subtotal, including 1 patient, take up to 2.9%, and the total is 34 patients, takes up to 97.1%. The average surgical time in our study was 128 minutes, with a minimum of 40 minutes and a maximum of 240 minutes. Due to the common bile duct perforation, according to our observation, these difficult surgical cases were prolonged due to the location of the stones, thickened gallbladder wall, and the degree of adhesion in the hepatobiliary triangle. Our surgical time was higher than reported in domestic study and international study, such as Nguyễn Tất Ngọc or Tomasu Kuruki. Well, the average blood loss during the surgery was 24.3 milliliters, with a maximum of 70 milliliters and a minimum of 5 milliliters. The case with the highest blood loss required to conversion to open surgery with difficult dissection due to adhesion. This study resulted in slightly higher than those reported, like Tomasu Kuruki, which is only 10 milliliters. In this study, we encountered 1 case of common bile duct perforation during the dissection due to the firm adhesion of the gallbladder and the biliary tract. Additionally, there was 1 case of duodenal injury caused by extensive adhesion, which made the adhesion lysis difficult. Bleeding is a leading complication in the surgery. We recorded 2 bile leak post-operative cases, takes up to 5.7%. Bile leak is a severe and a common complication. Our study is quite similar to both domestic and international study regarding the rate of post-operative complication. Our study did not report any other common complications after the surgery. Our research has the average length of hospital stay after the surgery is 6.5 days. Shortest is 2 days and the longest is 5 days. The longest stay is due to the critical medical condition, like patients have hypertension, diabetes, and a history of laryngeal cancer surgery. Our research shares similarity to Lê Quang and Thống, which is 5.25 days. And this is several pictures from the department we capture when we place a PTGBD tubes in patient. This one patient has a lot of bile liquid and a lot of mud inside. In conclusion, laparoscopic cholecystectomy after PTGBD has high successful rate with a low incidence of complication and perioperative adverse events. PD-GBD is an effective and easy to perform, a safe treatment method for cases of acute cholecystitis that are unable to undergo a surgery. This is the end of the presentation. Thank you for your listening. I wish you all have a nice day.